Thank you. I'm Todd. Just with the catchy title, my first entry into healthcare was working in a large academic medical center. And this is having come from Pillsbury, the food company, where the speed of change was so rapid, and our president constantly talked about how do we fill the cup 8/7 full. And then moving to an academic medical center in which everything went into a committee that ultimately went into this black hole to maybe resurface 6 to 9 months later with minimal or mediocre results was kind of the launch for this title. I've been in the change business for 25 years, and I will tell you that what I've experienced in the last 12 to 18 months at Stanford has been nothing short of miraculous. I think we've made this giant turn on 90 degrees and are taking 1-2 giant steps forward. And the person that's really been the catalyst for this change is my co-facilitator or co-presenter today, Amir Rubin, our president and CEO. So, Amir.
If Todd's the oxy, I'm the moron aspect of the duo here. So it's a privilege for me to be here, a privilege to get to work with Todd and a great organization. So what we'll do is we'll do a little bit of the propaganda, a little bit of the background, then talk about really this rapid change in the context of patient experience, but it really applies to everything that we're doing in the organization and our patient experience approach we call CI Care. But we'll talk about our change in the context of this change initiative. And then Todd will take us through some of the detailed steps. So what did we do, literally what did we do across the calendar to get things implemented, and what were some of the outcomes? And then how does this ultimately link into what we call our Stanford operating system, our approach to organizing how we do operations in the organization? So just a little bit of background. We started by re-examining ourselves, and we came up with a new vision statement. And our vision is healing humanity through science and compassion, one patient at a time. So Todd and I like to joke we have a lot to do by the end of the day because we have all of humanity to heal. But at some level, those are the big and bold objectives that we want to achieve at Stanford. And over the past 50 years, arguably, we could say we've made a little dent in this, and this is probably hard to read here, so I've highlighted some things, but we've had 6 Nobel Prizes, and we're a relatively young academic medical center. We just received another Nobel Prize a couple weeks ago in chemistry. My biggest challenge there was, is it EL or is it LE? So I had nothing to do with winning of the Nobel Prize, but it is a big part of who we are. We're really founded as a scientific organization. A lot of breakthroughs, so gene splicing, blood-forming stem cell identification at Stanford. The first linear accelerator, Dr. Henry Kaplan with Anywhere was at Stanford. The invention of the CyberKnife for stereotactic radiosurgery. First heart-lung transplant, development of balloon angioplasty, some of the early work in targeted drugs, Rituxan, a drug for lymphoma, developed at Stanford. So making a big impact on humanity is certainly part of what we do. And from a quality or patient care delivery, this is the propaganda of organizations. And we do okay on these things, and we want to do much better. And not that these are necessarily the end-all and be-all of quality, but these are some good institutions, US News, Leapfrog, magnet status, and other things. We were also relatively early on in electronic records. We were the 4th in the US to be designated as this HIMSS, Health Information Management Society, stage level 7. I got to Stanford almost 2 years ago. I'm like, great, we're done. It's all done. And no more needing to spend the IT budget on electronic records. And obviously, my other joke is if we're number 4, you should see number 5. They must look like hell because we have a lot of work to do. Also, though, ultimately, it's not about recognitions. It's about delivering of care. And a lot of us look at various measures. And for the University of Michigan people in the room, I did remember something about Avidus Donabedian, and that quality has 3 components: a structure, a process, and an outcome component. And increasingly on a national scale, we're moving a little bit more to outcome measures, but a lot of them are process measures. And those measures are fine and good, and I'm a supporter of them, but they don't always necessarily distinguish, certainly at least on complex conditions. So these are called Kaplan-Meier survival curves. So these are for very complex conditions, stage 4 metastatic breast cancer and metastatic colon cancer. And one of these is probably a pointer, but I'm sure I'll just turn off the screen. So needless to say, if we look here at the red curve, for example, on metastatic breast cancer, that is Stanford versus what's called the SEER national database. So at 2 years, we stay out from diagnosis, we have a 75% survival rate versus a national average of 49%. And so, and you see the same here in colon cancer. Again, these are very advanced, not good cancers to have, of a, if I can read that, 62% survival rate versus a national average of 24%. So ultimately, again, my marketing people don't advise this, but my kind of elevator pitch is you could go to the other place and die, or you could come at Stanford and live a wonderful life. So again, that's why I'm not in marketing. I'm in a different aspect. But ultimately, this is what we want to do. We want to help people survive and live healthy lives. And a lot of you all are leaders in these fields of quality and quality measurement and outcomes. So how do we put all this together, this kind of vision, this value, this focus on healing humanity, and how do we build it into our operating system? So this computer that we're projecting these slides on is running an operating system, and then we have applications running on top of it. Are there certain things that we can put into our approaches that we could build on top on? We can write the APIs, the interfaces, on top of this operating system so that everything we do will be designed for continuous improvement, will be designed to be as error-proofed as possible, will be designed to develop our team, our leaders, our staff in this model. So this is what we refer to in our Stanford operating system. And really what we're saying is we want to align our people with our purpose and our performance. So, align our purpose with our people and performance. And this is really just an annual planning cycle. So each year we take a look at our mission, vision, and values. We redefine our strategies. And then each year we set objectives. And we don't only set operating budgets and capital budgets, but we set detailed, what I like to call operating plans. Many of you may have these performance improvement plans. We set them down across the entire organization. Doesn't matter if you're in the chaplaincy, the valet parking, where are you today, where are we going to be, what are the steps you're going to take. And then we have a way we manage that performance. We have our Stanford operating system. We have monthly, we call them SOPs meetings, where people actually present in a standard format. But it's one thing to try to improve performance, and it's another thing to manage it or to sustain it, which reminds me of a Seinfeld episode. Anybody Seinfeld aficionados here? So Jerry goes to pick up his car rental. This is good, we're all traveling. At the rental agency, and he says, Mr. Seinfeld, I'm here for my car. And the clerk says, yes, we see your reservation here, but we have no cars. And he responds, well, anybody can take reservations. I can take reservations. The trick is keeping the reservations. And that's the other trick here with our operating system. And many of us have been involved in performance improvement efforts, or many of you have tried to launch ones, and you've had people on the team said, we've done this before, it failed. And maybe actually what you did before was right on. There was just never a plan to sustain it. It was never built into the operating system. So let me talk about some of the things that we are components of our operating system that we use to improve and sustain, and then hand it over to Todd to give us some details on how we've done this with our patient experience approach. So, and a lot of this is common sense. The trick is doing it each and every person, every time, with every initiative, always. So we have to start with an evidence-based standard work. In Lean, we subscribe to a lot of Lean tenets. So Lean, the parlance is standard work. In healthcare, we talk about evidence-based things. So I just combine the two. It's evidence-based standard work. But is there a best way of doing something? If there is, we should write it down. And if there is, we should hire for it. We should train on it. We should retrain on it. We should reinforce it in huddles. We should reinforce it visually. We should measure it. We should go and observe it. We should reward and recognize it. We should continuously improve it, and we should develop our leaders on it. If there is. If there isn't a best way or a standard way, then okay. But if there is, if we don't have these 8 or so components, I would say, and I was talking with Christy Lamack before, this is the good thing about being in management versus academia. I would say with absolute certainty, one cannot sustain performance. Now again, I don't have to prove it. But so these are what we say are our key components to sustaining performance. And in our patient experience, we started with a very basic motherhood and apple pie a template of CI care. These are things we should do when we connect, when we interact with our patients. We should C, connect with them. I, introduce ourselves and our role. C, communicate what we're going to do. A, ask permission, respond, and exit. And many of you probably have some similar things like this. We actually went out, though, and engaged our entire health system, frontline staffs, in defining specifically what it means for a nurse, what it means for a doctor, what it means for an intern or a resident, what it means on admission, what it means on discharge, what it means in the billing shop. So, and then said, and it's not, once we define these things, it's not optional, it's what we do. And we reinforced it through our daily huddles in every single department through our health system and through our visual walls. We actually go and observe. We talk to patients and we talk to staff. We talk day shifts and night shifts. We actually track who goes out. We take attendance on rounds. It's not a good idea. It's what we do. Somebody sent me this slide. And we've put ourselves in standard appearance too. You couldn't tell who was a nurse, a secretary, what have you. So we now have standard uniforms. So with that, I'm going to turn it over to my partner, Todd, to share how it is we went about this change process.
Thanks, Amir. So when we take a look at change and Amir joining the organization, there is only one change to go after, and that's changing the culture. And if you think about that storied history that Amir talked about before, clearly a lot of things were embedded in the culture. So how we approach changing the culture, how we're doing that at Stanford now is two ways. One is changing our processes, and as Amir mentioned before, utilizing lean processes and systems, and then changing behaviors. And so it's looking at that combination of those world-class practices in conjunction with world-class interactions, CI care. And what we say about CI care is this is standard work for human interactions. Likewise, you have standard work in the workplace. We have standard work for human interactions. And so what I'm going to focus on now is what we did related to instituting CI care at Stanford and the process that we went through. Again, Amir just walked you through this slide, but here's what CI care is one more time. And I think the main piece here is every patient, every time. So here's the rapid change part. This is the money shot, if you will, from a slide perspective. So looking back to January of 2011, Amir joins the organization in January. Amir joined on January 3rd or 4th. The following week, we had a monthly manager meeting. On the agenda was patient satisfaction. We spent an hour or so of that monthly manager meeting talking about what we're doing, what is the patient experience that we're trying to create. Now, throughout the organization, everyone was working on patient satisfaction, but everyone was doing something different. Words that work, Ate It from the Studer group. Everyone was doing something a little bit different. Next month, February, at the monthly manager meeting, Amir introduces CI care, introduces the acronym CI care, explains it, talks about it, gives us a chance to take it on, experience it, role play, work with that in the organization. 1 month later in March, monthly manager meeting. Amir announces, everyone in the organization will create CI care templates for their department. On tax day, April 15th, I want you to use CI care templates to create human interactions for each of your standard practices within your area. So at that point in time, behind the scenes, we convened a group called the Patient Experience Planning Committee, led by senior leaders in the organization, supported by my group, the Organizational Development Team, and a Performance Excellence Team, and looked at supporting the patient-facing areas to help them create these templates, standard templates for their areas. So in ambulatory, Departments got together with their staff and utilizing CI Care, created templates related to how are we going to check in patients? How are we going to room patients? How are we going to discharge patients? Or check patients out. Transporters. What's your human interaction utilizing CI Care as you're transporting a patient? Environmental services. As you enter the room to clean the room, what's your CI Care interaction? And we created words that work following that template for each of those areas. April 15th, 104 department-specific templates were created. All right, that's great. Now we have the templates. What do we do? It's behind the scenes. We're going to train 6,700 employees on CI Care and these templates. And we're going to start that in May with the leaders in the organization. So behind the scenes, my team is working diligently, directly with Amir, to develop education for all of our managers. And in the month of May, we trained 600 managers in a train the trainer session to teach all of their employees on what CI Care is, on 3 universal practices that we had identified: wayfinding, answering the telephone, and service recovery, as well as their department-specific templates that they had created. From June through September, we trained 6,700 employees on CI Care and those departmental templates. So huge rapid change, inclusive of the entire enterprise. In September, we started to introduce recognition. So going to our earlier presentation, people do what they're rewarded to do. So how do we align our incentives to what we're trying to accomplish with CI Care? So put in place recognition. In the fall, we then went into the second phase of CI Care, which is what we call our active daily management, the things that Amir had talked about on the earlier slide, rounding, huddles. And we actually taught all of our leaders, what is the way we want that done? How do we want to do all of those things? How do we want to create visibility boards? What are the metrics that we're going after? And so putting in place standard work for our leaders. Next, Amir did a great job working with the dean and introducing and getting buy-in and support from our physicians. As you know, in hospitals, it's really critical to have alignment and their support. And it was fun to watch the physicians kind of peek up over the corner and look at what we were doing and seeing the things that were happening. And then in December, we launched management rounds. Fascinating. So every month, and once a month during the day shift and once a month during the evening shift, 660 managers will congregate at different locations throughout the system. And at the same hour, at the same time, we'll go into the organization and round on staff, asking our employees about CI Care, asking about the training that they've received, interacting with patients to see and get feedback from the patients to make sure that CI Care is in fact happening in the organization. Amir leads and facilitates each and every one of these sessions, so clearly it's institutionalized and seen as valuable in our organization. It was great. One evening we were in a meeting and Amir said, I've got an evening dinner. I'm not able to attend the management rounds. Do you think people will see that I'm not committed? And that was quite funny since clearly a huge investment on his part. And then recently, this last winter, we created an application for iPads and so forth, where we go in and we track the rounds that are taking place. The expectation is that each manager will round on every employee every month, and we'll track this in this particular application. We track recognition, so as you're putting in your recognition card, it's being tracked online, and you go in and you enter that information. So what it does for our leaders in the organization, it creates a dashboard. So they can track what managers are doing what as it reflects and relates to CI Care. So again, in addition to this all happening in the last 12 months, again, it's really reinforcing that standard work for leadership based on CI Care. Recruiting, so we use a pre-assessment that we use on all employees in the organization, from frontline staff to senior executives. We utilize behavioral-based interviewing, train and develop standard ways to develop or bring on board our new employees. Again, conducting the huddles, displays, rounding, et cetera. The one thing that's been great about CI Care from a change management perspective is we have 7,000 employees that understand standard work. They understand what it means to do standard work. And as we move into our lean initiatives and our lean processes, it helps them understand the value of standard work. And so our process is simply learn and see what are the processes of the work that we do. Do we understand what's value added for our patients? Second step is really organize the areas. 5S. Clean, sweep, sort, and just thoroughly clean up the areas that we're working on and sustain that. Again, what that is not a huge thing, and at the same time, it reinforces that standard work in the organization. And then lastly, our plan, do, check, act, continuous improvement areas. So as we get more sophisticated with our lean journey, people will be able to get on board because of their understanding of standard work. Also, this is our value stream for leadership development. This is how we grow and develop our leaders at Stanford. So cycle one is really onboarding. How do we onboard our new leaders? Get them assimilated into the culture. Second cycle is really our lean, making sure that they understand the tools, methodologies, and more importantly, the mindset related to lean. Cycle three is management skills. How do we assure that our leaders have the blocking and tackling skills required of leadership? Cycle four is really around leadership presence. So how do we make that transition from management to leadership? And then cycle five is really our talent profiling. How do we track our employees in the organization, kind of a succession planning, if you will. If you notice on the left-hand side, these are the different levels that we're tackling right now. Notice the coaching aspect. The coaching piece is significant for us. We believe that every leader needs to be a coach, and every leader needs a coach. And so how do we bake that into what we're doing from a leadership development perspective? So lessons learned over this past 12, 18 months, kind of modeling Kuz's and Posner's work. Leaders model the way. And so one of the things that leaders have been involved with CI Care all the way, leaders as teachers, leaders modeling CI Care, and actively participating in all the rounds that we do organizationally. Inspiring a shared vision. As an employee, it is a breath of fresh air to be healing humanity through science and compassion, one patient at a time, as opposed to being the best academic medical center. CI Care best practices, challenge the process. Everybody, every patient, every time, evidence-based. So how are we utilizing the lean principles and tools, enabling others to act, following that standard work? And then lastly, encouraging from the heart. We have great stories, and we share those all the time. So what's the result of this work over the last 12, 18 months? If you go to Q2, we were at the 72nd percentile in press gaining for likelihood to recommend, and here we are 12 months later at the 92nd percentile. That's a significant jump and one that we're extremely proud of. The other piece is the culture aspect that we were trying to change. Quick story, I was meeting with one of our nurse managers a couple weeks ago, and she said, remember that training you did last year? I just really want to thank you for that. And I said, the CI Care training? She said, yeah. And she said, I am so proud to work at Stanford. I walk into the hospital today, I see all the employees helping people who are lost and can't find their way and need some wayfinding. I see people smiling, I see people interacting in a whole different way. Not only did she share that from the organization, but her department as well. So I too am really proud to work at Stanford and think that we're doing some great things and we're on our way. So thank you for your time. Break and questions. We're out of time, but I think we're okay.
Quick question. Give us a sense of the metrics that you have followed, and then have you seen changes in critical areas such as hand washing for the staff, wound infections, and readmissions, things that impact the bottom line of every hospital?
Yeah, so our kind of active daily management approach, there's nothing here at the end of the day that's so secretive that wouldn't apply to anything. So I make the comment, if you want to maintain performance on centralized bloodstream infections or ventilator-associated pneumonia or hand washing, right, is there a best practice? Did you train on it? Is it huddled on? Is it rounded on? Is it reinforced? Where we've done that, we went 1.5 years without a central line bloodstream infection in our ICUs. That was pretty good. But I got to say, there's other areas where we definitely have problems. So by no means would I say we're at perfection everywhere. But once we kind of have this operating system construct, we have team members, and they'll come up to us and say, well, I know it's not going to sustain because we don't have these 6 components. It's not in the recruitment. You don't have a retraining it. You train people once, and you think that'll stick that way. There's no measure on it. It's not reinforced in a huddle. There's no tie to any recognition. We know it won't work. So I think what's powerful is we believe we have a model that we've trained our leaders in that can apply to different quality improvements.